Hello, my name's Aileen Chang, and I'm an associate professor of medicine at George Washington University. Today, I will be talking to you about translational studies for emerging arboviral pathogens. Arboviruses are viruses that are spread by insects like mosquitoes. For example, this is a picture of the Aedes mosquito that spreads dengue, chikungunya, yellow fever, Zika, Venezuelan equine encephalitis, filariasis, and Rift Valley fever. Vector-borne disease represents more than 17% of all infectious diseases, causing 700,000 deaths annually. Today, I'll be talking to you mostly about the arthritis that is caused after chikungunya virus infection. Chikungunya was new to the Western Hemisphere in 2014, and this is a picture of a woman affected by chikungunya from the outbreak in the Dominican Republic in 2014. Chikungunya tends to cause an abrupt onset of fever and significant joint pain that's often severe and debilitating, involves multiple joints, usually involves bilateral and symmetric joints, and it most commonly affects the hands and the feet. For chikungunya treatment, there's no specific antiviral treatment. There's just supportive care with rest and fluids and acetaminophen for acute fever and pain. For the persistent joint pains, the only treatments that are used currently include NSAIDs, corticosteroids, and physiotherapy. But fortunately, there was just approved a new FDA live attenuated single-dose vaccine targeting chikungunya virus. My work is translational, meaning that I focus on the intersection between basic research and clinical research. And I work with multiple collaborators in the US, particularly collaborating with the US Navy and the US Army, in addition to multiple collaborators in Colombia and Brazil. These are some pictures from our Colombian clinical site in Barranquilla and some of our other investigators, our laboratory facilities, and patients. The first study that we did of patients with arthritis after chikungunya was a study where we looked at a cohort of 500 patients and assessed how many of them had persistent pain attributed to their chikungunya infection 20 months after their infection. And we found that approximately 1/4 of the patients reported persistent joint pain. In a multivariate analysis, we determined that there are certain variables that were associated with persistent joint pain, and those included college graduate status, initial symptoms of headache or knee pain, missed work, normal activities affected, or 4 or more days of initial symptoms or 4 or more weeks of initial pain, indicating that a more severe initial infection was more likely to cause persistent arthritis afterwards. So we wondered what the mechanism was. We know that chikungunya evades neutralizing antibodies by hiding in apoptotic blebs. And on the figure on the left, the top figure, you can see chikungunya in apoptotic blebs inside of a macrophage in a patient 18 months after infection. And on the bottom slide, you can see chikungunya by immunofluorescence highlighted in green. We know that while chikungunya is in the blebs, it can infect neighboring cells, and that viral replication in macrophages does not yield a pro-inflammatory response. And that, in fact, chikungunya inhibits RNA kinases needed to make antiviral mRNA transcripts. So that led us to the hypothesis that perhaps chikungunya remains in the joint as the causative mechanism for persistent arthritis. We were funded by the Rheumatology Research Foundation to investigate this hypothesis. Our plan was to determine if chikungunya persisted in synovial fluid post-infection, potentially serving as a causative mechanism for the persistent arthritis. So in our clinical site in Barranquilla, we designed a pilot cross-sectional observational study, and we enrolled 38 patients with chikungunya infection during the epidemic with chronic arthritis and another 10 location-matched controls without prior chikungunya infection or arthritis. We confirmed these infections with chikungunya IgM and IgG ELISA. We also did a arthritis disease activity score. as well as collecting blood and synovial fluid samples in order to analyze them for PCR, viral culture, and mass spectrophotometry to identify viral proteins. Here's a picture of our cohort. Our cohort is predominantly women and rather young for an arthritis cohort with a mean age of 56. And most of these patients did not have any arthritis prior to their chikungunya infection. Here's a picture of the hands of one of our patients after chikungunya infection. You see that most of our patients have joint tenderness, joint swelling, joint stiffness, fever, and rash during their acute infection. And afterwards, we found that the small joints were predominantly affected, including the elbows, wrists, fingers, ankles, and toes. And as the time after initial infection progressed, oftentimes these joint pains progressed to knees, hips, and in some cases, shoulders. The disability in the chikungunya patients was significant, with approximately 80 having an effect on their activities of daily living, approximately a third with missed work. The patients had about 5 tender joints and about 3 swollen joints, and the disease activity score mirrored that of rheumatoid arthritis. Our primary outcome was the analysis of the synovial fluid, and in the synovial fluid, we did not find evidence of chikungunya RNA and it was PCR negative. We did not see any evidence of viral proteins by mass spectrophotometry, and the chikungunya culture was also negative. This was the largest observational study to follow synovial fluid to date, and the synovial fluid analysis revealed no evidence of chikungunya. These findings suggest that chikungunya may cause arthritis through induction of host autoimmunity, or that periods of remitting disease can only be identified in the synovial tissue. As such, immunomodulating medications may play a role in the treatment of chikungunya arthritis. Therefore, we designed a study of methotrexate in the treatment of arthritis, and we named that the MARCH trial. This is a randomized controlled trial of methotrexate versus placebo in the treatment of chronic arthritis after chikungunya infection that's funded by the National Institute of Arthritis and Musculoskeletal and Skin Diseases. In this trial, we randomized patients to 2-to-1 to methotrexate to placebo in the first 6 months, and then there's an open label phase of an additional 6 months of therapy with a 1-year follow-up after that. And additionally, we biopsy the patients in a subgroup before starting therapy and within 6 months to look at their synovial changes. The objectives of the trial are to determine the efficacy of oral methotrexate versus placebo for 6 months in chikungunya arthritis, and to determine the effect of methotrexate on synovial inflammation and mechanisms. Here you can see a figure of what we think is going on in the joint of a patient with chikungunya arthritis. Chikungunya is known to infect synovial sites and macrophages, and to increase IL-1, TNF, GM-CSF, and IL-6. Therefore, it appears that there may be a vicious cycle of inflammation, and we hope that the methotrexate will work by breaking this cycle via inhibition of IL-1 and IL-6. We also do biopsies. This is a picture of one of our patients being biopsied in the knee, and this biopsy is performed prior to treatment and after 6 weeks after initial treatment. We score the synovial inflammation and use immunohistochemistry to evaluate the presence of T cells, B cells, and chikungunya in the synovial tissue, and we'll also use RNA-seq to evaluate the transcriptome. Our hypothesis is that chikungunya arthritis will demonstrate infiltration of leukocytes into the synovial tissue that will correlate with disease severity, and that treatment with methotrexate will decrease the accumulation of macrophages and T cells in the synovial tissue and decrease inflammatory signaling. We're also working on a pain supplement in order to measure additional functional pain metrics that characterize nociceptive, neuropathic, and nociplastic pain phenotyping in this Latin American cohort. And we also include assessments of social determinants of health as a modifier of pain severity in response to treatment. In order to determine the effect of methotrexate in bidirectional interaction between tissue damage and pain mechanisms via peripheral blood and synovial tissue analysis, we will be measuring CGRP, substance P, and nerve growth factor, in addition to cytokine profiling and single-cell RNA-seq transcriptomics and ATAC-seq chromatin analysis to determine if they correlate with particular clinical states of pain. This is a picture of our recruitment activities in Barranquilla, Colombia. So we spend a lot of time engaging with patients and local communities to discuss the trial. And we do community engagement events where prospective patients come, and we do joint examinations and community education as well. Another thing that we do to facilitate the research and the trial is we've developed a chikungunya-specific disease activity score. And then to develop this score, we amassed a group of rheumatologists and biostatisticians in order and analyzed the data from our Colombian cohort in order to determine how disability, pain, physical and mental quality of life, and mobility were related to different metrics so that we could design an improved disease activity score. And here you can see that this is the result disease activity score that appears very similar to the disease activity score that is used in rheumatoid arthritis, with the addition of the tender ankle that is not measured in rheumatoid arthritis that becomes important in chikungunya arthritis. And lastly, I'll talk a little bit about our research involving interleukin-2 as a potential chikungunya arthritis therapy. When we learned originally that the arthritis is likely not related to persistent live chikungunya infection in the joint, then I started to wonder what could be causing this arthritis. And one of the things that we did was we did DNA methylation studies to compare between patients with chikungunya arthritis and normal controls. And we found an alteration in multiple genes involved in regulatory T cell function. For example, we found a change in the GARP gene that was hypermethylated in patients with chikungunya arthritis. And it's interesting because this gene is important in rheumatoid arthritis disease activity. This gene is important in the presentation of TGF-beta to signal naive T cells to develop into Tregs. To further work on this, the next thing we did was we looked at the cytokine profile of patients who had chikungunya and developed arthritis years later, or continued to have arthritis years later, and patients who had chikungunya and did not have arthritis years later. And we age and sex matched those patients. And we observed that low TNF alpha, IL-13, IL-2, and IL-4 during the initial infection were predictive of having chronic pain later. So that got us looking at interleukin-2 as an important cytokine in the development of Tregs and perhaps in the pathogenesis of chikungunya arthritis. Tregs function to decrease inflammation, and you can see in the figure on the right that with low-dose interleukin-2, that can lead to Treg expansion and activation that leads to decreased effector T cell function, B cell activity, and effector CD8 T cell activity. In the setting of adequate interleukin-2, as you can see in the normal suppressive function figure on the left, the Treg has adequate expansion and activation, and this inhibits the effector T cell, leading to control of local inflammation. However, when interleukin-2 is deficient, as we found in our patients who were likely to develop arthritis later, we find that there's a lack of Treg expansion and activation, and there's effector T cell proliferation, leading to increased local inflammation. So we questioned whether novel low-dose interleukin-2 therapies might be effective for autoimmune disease to upregulate regulatory T cells. So we went back to our cohort after 3 years after their chikungunya infection, and we found that 1 out of 8 of those patients still had arthritis that they attributed to their chikungunya infection. So we asked, could we use low-dose interleukin-2 as a chikungunya arthritis therapy? So with the funding of the National Institute of Health and the Pharma Foundation, we did an analysis of cytokine and T cell responses in post-chikungunya viral arthritis in a cross-sectional study. And the purpose of this study was to define the relationship between chronic chikungunya post-viral arthritis disease severity, cytokine response, and T cell subsets in order to identify potential targets. So we enrolled the Colombian cohort. We assessed arthritis disease severity, and we also measured cytokines and measured peripheral T cell responses. And this is what we found. We found in general that the patients with chikungunya arthritis had low interleukin-2 levels, but in those who had a little bit higher interleukin-2 levels, that it appeared to cause an expansion of regulatory T cells and an expansion of activation markers of regulatory T cells. So then we did an arthritis mouse model. And in order to do this mouse model, we inject mice in the foot pad with chikungunya virus. We confirmed that they developed chikungunya virus by PCR. And then we wait until they're no longer PCR positive, meaning in order to recapitulate the natural infection in humans, as the patients are, when they have arthritis, are oftentimes PCR negative. And then we treated these mice, with IL-2 monoclonal antibody and the complex of IL-2 and monoclonal antibodies. And on day 19, we sacrificed the mice and collected blood, splenocytes, tarsal joints, and did cytokine and T cell analysis and immunohistochemistry. So here you can see the tarsal joint histology, and you can see in the diseased area a significant infiltration of these purple blue T cells. And further, on the figure on the left, you can see the bony erosions, and on the figure on the right, you can see cartilage erosions as a result of chikungunya infection. We developed a tarsal histology score based on synovitis, cartilage erosion, bone erosion, and muscle degradation. And we found that those mice that were treated with the anti-IL-2 monoclonal antibodies had the lowest inflammatory pathology score. And in the therapy groups, you can see here that as we provided therapy to the mice, that the control group PBS in black had control or negligible IL-2 present, that the maroon IL-2 group shows somewhat increase in interleukin-2, and that the anti-IL-2 monoclonal antibody had a significant increase in interleukin-2, likely due to increasing the half-life of that molecule, and that the complex was significantly increased above that in green. Our flow cytometry results showed that the complex had increased regulatory T cell frequency and also increased activation markers such as helio and increased activation markers such as helios. So in conclusion, we found that interleukin-2 based therapies are effective in treating chikungunya arthritis in a mouse model and reduce the intensity of disease, and that specifically the interleukin-2 complex increased Treg frequency and activity. Therefore, our next step is to look at the value of interleukin-2 in a clinical trial. So we have now designed a Phase 1/2 adaptive dosing clinical trial to assess the safety, tolerability, and preliminary biologic efficacy of interleukin-2 treatment of chikungunya arthritis. And that's our next step. Thank you very much for your time. I'd like to thank my staff here and collaborators that made this work possible. Thank you.